Good morning, and thank you for joining us for today's event, Superbugs, Policy Solutions to Tackle an Emerging Health Threat. My name is Josh Resnick, and I'm publisher of CQ Roll Call, as well as President and Chief Operating Officer for Fiscal Note. Before we begin, I'd like to take a moment to thank our sponsor, Pfizer, for partnering with us to make this event possible. Kicking off today's program is a discussion with Senator Todd Young. Interviewing the Senator is Dr. Michelle McMurray-Heath, President and CEO at BIO. Michelle, the floor is yours.
Thank you, Josh. It's a pleasure to be here, but I can't emphasize enough the urgency of the fight against antimicrobial resistance, or AMR. The leaders joining us today recognize what's at stake. For those in our audience who are unfamiliar with this issue, I want you to think about what you expect when you go to a hospital or receive treatment for an illness. You expect to get better. But because we have overprescribed antimicrobial medicines and failed to support efforts to bring new ones to market, bacterial and fungal infections that we once faced down are now killing patients. These are people who expect to recover, not find themselves in a new medical battle. And as a result, AMR is one of the greatest public health threats of our time. Globally, in 2019, drug-resistant bacterial infections killed over 1.2 million people and played a part in nearly 5 million deaths. The Lancet recently revealed that AMR is now a leading cause of death worldwide, higher than HIV, higher than malaria. And COVID-19 only intensified AMR. The CDC announced last week that the pandemic caused a surge in superbug infections and deaths in US hospitals due to sicker patients, overuse of antibiotics, and overburdened hospitals. Infections and deaths from dangerous bacteria increased 15% in 2020. Many survived COVID only to succumb to AMR. And unfortunately, there is not an arsenal of new antimicrobials to fight resistant infection. The time to develop these new drugs is now. But there are only 64 new antibacterial drug programs in development worldwide, and more than 80% of those originate with small companies. BIO represents many of these small biotech companies, and we know that they create miracles, but small companies face long financial odds, especially in today's economic climate. And those specifically working in our flawed antimicrobial market need stronger financial incentives in order to get products to market. Senators Todd Young and Michael Bennet are the bipartisan co-sponsors of the PASTEUR Act, a bill designed to create those incentives and save patients' lives. I'm now going to discuss this critical issue with Senator Young, as well as impress upon everyone the urgency of acting. COVID taught us many things, and one of those should have been the importance of addressing health challenges before it is too late. AMR superbugs are expected to kill more than 10 million people annually by 2050. We need to act now to build the drug pipeline and life-saving measures that we need. So let me bring in Senator Young to talk more about antimicrobial resistance. Senator Young, first of all, thank you for joining us, and thank you for your commitment to this issue. I wanted to know what about AMR first caught your attention and caused you to become one of its standard bearers.
Well, thank you, Doctor. Thank you for having me on today. I want to thank Roll Call and Pfizer for hosting this event. Listen, this issue first caught my attention because I heard about the human cost associated with antimicrobial resistance. You touched on some of the figures earlier. The Lancet's revelation that AMR is now a leading cause of death worldwide, higher than HIV, AIDS, or malaria. That alone is compelling. U.S. Centers for Disease Control recently indicated that we lose someone in the United States to AMR every 15 minutes. This results annually in at least 35,000 lives lost. And so this is obviously a very important and costly public health threat. And the gravity of this threat is only worsening. We're seeing the resistance grow by these so-called superbugs to existing medicines. And as you quite accurately said in your lead-in, we don't have sufficient incentives to lead to the sort of pipeline of antibiotics so that we can address these things. So that's what catalyzed my interest and caused me to work with Senator Bennet and a number of outside expert stakeholders to come up with a different payment model that might help, if not solve this problem, significantly reduce its human cost to Americans and frankly, to people around the globe.
So you've been out around the country talking about this important issue for a while, and I'm wondering if it's given you any insights about how we can improve the sense of urgency. You know, how can we get people to focus when there's so many other competing priorities?
Well, we learned during the COVID pandemic that diseases don't care whether you're a Democrat or a Republican. So anyone who had some measure of insight into how we can overcome COVID and seemed to have answers about how we might get past some of the challenges we're facing in our lives was a unifying force. And our similar hope here is that as it relates to antibiotic-resistant bacteria, we can all regard that as an equal opportunity enemy and figuring out how to address that antibiotic resistance. Bacteria is always going to be evolving in new ways to defeat the drugs that we now have, and new therapies will, of course, always be needed to address emerging resistance. So we are literally in a race, and it's a race with these relentless microorganisms that we can't afford to lose. We have to win this thing. And I found that message really resonates with people regardless of their political affiliation. And I think we need some issues as a country to rally around right now. It's no secret that we're divided on a number of fronts. This is a common enemy that all of us can unify against, and frankly, it's in the grand scheme of things, it won't cost a lot of money. It won't require tons of sacrifice. It just requires a new way of thinking and the intelligent allocation of resources so that we can improve lives, extend lives, and avoid risk.
I love that. I'm going to use that equal opportunity enemy because I think it so captures it. I think a lot of people think of penicillin as something, you read about in the history books. We developed it, we've won that battle, and it's gone. But actually, you point out that the bugs are continuing to change and we need to adapt as well. So what is some of this new thinking? Can you unpack for us a little bit about what the PASTEUR Act is and how it would work?
Well, in short, the PASTEUR Act would create a subscription style model under which the government pays companies to set amounts for access to new treatments based on a treatment's value to public health. So typically we'll compensate our drug companies, our pharmaceutical innovators based on the volume of their sales. And this is a different way of thinking. We want to do our best to quantify the value to the public, and that on the front end would incentivize the development of these drugs. So I can get into some more specifics. PASTEUR contracts would identify specific features that are important to our public health, and to the extent those features can be met by innovators, we will pay the innovators for their breakthrough research. The approach attempts to solve a core problem that's facing antibiotic drug development. The need for drugs that don't have high sales potential right now in the private drug market. And we think it will accomplish that in fairly short order. It will encourage the development of those new types of antibiotics, and it will also help ensure that patients have access to the drugs once they come to market. Antibiotic resistance, you could also argue, is a national security issue. And I think that's important to underscore. These multi-drug resistant superbugs threaten our own citizens, but also our armed forces, who are at risk of battlefield trauma, and ultimately, should these superbugs take hold, it could undermine our military's force readiness internationally. In fact, if you look at the number of military casualties in some of our largest conflicts, they tend to be a function of disease, not of direct military engagement. So there's no reason for us to be caught flat-footed. We know that there will be an inevitable superbug outbreak. And so if we prepare now through an intelligent reworking of our compensation models for breakthrough innovations, we can avoid those risks and do right by all of our constituencies.
I mean, I love that you point out the national security issue. You only have to Google the history of penicillin to know how big a role it played in world wars. So it's important to know that after trauma, having an infection is very common. And so having the tools to fight that infection is key. And it's interesting that in the PASTEUR Act, you're focusing on rewarding the innovators for how effective and how safe and how targeted the therapy is at a public health threat, rather than volume of sales, because these are things we want to use sparingly, right? Not like a vaccine or many other drugs. So you're gaining support and momentum here. You have 40 new co-sponsors between the House and Senate bills, as well as many mentions of AMR in congressional hearings since January. Novel pull incentives, and specifically the PASTEUR forums, have really made their way into the president's budget request to Congress. So how can the viewers today play a role? How can they help you? How can they support? How can they learn more?
I'm glad you circled back to that. So the call to action is we need more patient advocates to share their stories and to highlight the real challenges that we face with this resistance. I know we can shine a bigger light on this challenge. This has already been getting a fair amount of press, but I think it's important that we double down and get more members of Congress involved in getting this solution, the PASTEUR Act, across the finish line. By telling those compelling stories, by continuing to engage with members of Congress when avoiding health catastrophes it remains at the top of our agenda, we can make the best of this crisis and optimize some of our payment models in a way that will really improve public health as we head into the future.
Thank you, Senator Young, for all of your work in this space. We really appreciate your visionary work here. Now we're going to hear from Senator Bennet, your real co-drafter of this legislation, and his views on the issue. So thanks again for joining us.
Thank you.
Hi, everybody. It's Michael Bennet, and I'm grateful to have the chance to join you today to talk about this critical issue. The last 2 years of COVID have taught us that we can't afford to sit on our hands and wait for the next crisis to arrive. We have to anticipate the crisis and act now. And if you talk to some of the leading health experts in the world, what they've become concerned about is antimicrobial resistance. A combination of overprescription, improper use, and a massive market failure are producing more antibiotic-resistant infections every year. According to a CDC report from last week, the COVID-19 pandemic caused an even greater surge in resistant infections. So if we don't act, resistant infections will be the leading cause of death by 2050. We can stop that from happening, but we need to be clear-eyed about what works in the current system and what doesn't. One bright spot from the past 2 years is America's biotechnology sector, which remains a powerhouse for global innovation and production. Another is the strategic partnership between biotech and the federal government, which is how we broke every record for vaccine development and production. But right now, our system rewards volume, not value, which has led to massive overuse of antibiotics, skewing reimbursements and the incentive for private investment. This has crushed innovation and shrunk the pipeline for next generation antibiotics. We have to fix that, which is why Senator Young and I introduced the PASTEUR Act. In our view, it's the strongest bill ever written to strengthen antibiotic development and use. Our bill invests billions of dollars to fix the market failures we have today and transition us to a subscription model. Under this model, the government compensates pharmaceutical companies by value, not volume. We're giving them a guaranteed return for their product, and in exchange, they have to provide antibiotics to patients at no cost and be better stewards. We strongly believe the PASTEUR Act reflects a common sense approach to the crisis, and Senator Young and I are working hard to get this bill over the finish line. I don't think we have any time to waste. Thanks for everything you're doing.
Thank you, Senator Bennet. I'm Jessica Werman, Health Policy Editor at CQ Roll Call. I'd like to welcome our panelists, Thomas Heyman, President and CEO of the Sepsis Alliance, and Dr. Helen Boucher, Dean ad interim and Professor of Medicine at Tufts University and Chief Academic Officer of Tufts Medicine. Thomas, Helen, thank you so much for joining us today.
Thank you.
Thank you.
I'd like to start by making this kind of a personal sort of question. You both are obviously subject matter experts on this. Tell me a little bit about how you got involved in this. Dr. Boucher, it kind of makes sense that you would. You're a doctor, but maybe you could talk a little bit about how this became sort of a passion, because this is definitely something that you focus on as part of your work.
Yeah, so Jessica, thanks for having me. And, I got interested in antibiotic resistance very early in my career in the lab, but pivoted to this focus on advocacy in around 2007, when we started to see patients succumbing to these infections. And I started to encounter patients for whom I didn't have options to treat them. And so I've had the unfortunate experience of having to tell a 42-year-old man that we had nothing to treat his infection with and having to send him home on hospice for an infection that earlier in my career would have been curable, right? In infectious disease, we cure infections. So I had to tell this man, who I can see in my mind right now, who had 2 young boys, I had to help him go home on hospice to pass away because we couldn't control his infection. So the fact that this problem is now impacting patients in the hospital, people in the community, people like you and me today, and impacting my ability as a physician to deliver healthcare is what has brought me to have such passion about working to solve this problem.
Thank you. Mr. Heyman, you have a fascinating background as well. You come from A&E, you're an author. How did you get involved in this issue?
Yeah, and thank you, Jessica, and thank you to Roll Call, Fiscal Note, Pfizer for the opportunity to join the discussion today and for bringing attention to such a critical public health crisis. My story is very different from Helen's. I was the black sheep of my family. My dad was a doctor. My brother's a family doctor, and my son is a third-year resident now at Yale in internal medicine, and I went into media and marketing. So the black sheep, I guess it was intended that I would come back to healthcare eventually. I was serving as the general manager of the Biography Channel, had written several books on statistics and popular culture when I met Dr. Carl Flatley. And Carl was a wounded guy, but determined following the death of his daughter Erin to sepsis, which, as we know, is the body's toxic reaction to an infection and often the pathway to death or disability. When Carl told me about sepsis and that it was killing people like his daughter every 2 minutes in the US, I found it hard to believe. After all, if something was killing that many people, surely someone would have done something about that. Well, I was wrong, and Carl was correct. When Erin died in 2002 of sepsis following what should have been a routine outpatient surgery, the CDC did not have the word sepsis in its lexicon, nor did Microsoft. So in fact, if you type sepsis into a Word document, it would get caught as an incorrect word. So I was hooked. I had to join the fight. And shortly after joining Carl and Sepsis Alliance, I lost a dear friend to sepsis, and my daughter lost a good friend, age 18, to sepsis following an infection during his cancer care. So I was all in to figure out how we could solve this.
When we talked about this issue last week, Dr. Boucher, I was struck by something that you mentioned, which was that there's no breast cancer alliance for AMR. There's not, I mean, there's this for AMR. I mean, there is this, you've got the sepsis alliance, but for antimicrobial resistance, there's not the same level of awareness. And that's important. You know, there is something to be said for being able to focus on an acute challenge. Why isn't there more awareness, do you think?
Yeah, it's a really good question. It's an important observation that in the year 2022, when we have a report like the one that was just reviewed by our senators talking about the impact of AMR and how it could be worse than COVID, we don't have a patient voice that is loud and present, like, for example, the Breast Cancer Alliance. I think it's for a variety of reasons. Antibiotic resistant infections affect patients with many diseases. There's not any one disease, right? Little babies born prematurely in the ICU, people with cancer getting chemotherapy, people getting organ transplants, and regular people, college football player who gets a skin infection from the turf, right? All across the lifespan. So that's one issue. Nobody owns it. No, kind of medical group owns it. Another issue is that these infections are problems when they happen in the hospital, right? We do lots of work in the healthcare system to prevent infections, everything from washing our hands before we examine patients to doing procedures very carefully with the bundles of interventions to prevent infections. When infections happen in the hospital, they're reportable on the website. And so having antibiotic resistance is not something people want to brag about. So early on, and to some extent today, there's a hesitancy at the health system levels to allow physicians like me, even with patients who want to speak to the media, to have them speak to the media. That's gotten a little better, but that's still an issue. This is a very kind of unpopular topic. No one wants to be a center of excellence in antibiotic resistance.
Mr. Heyman, can you address it a little bit? I mean, I'm curious as to, I mean, you focus on sepsis, but to what degree is AMR awareness part of the work you all do?
Yeah, it's critically important. I mean, sepsis is when an infection goes bad. So you don't die of an infection, you usually die of sepsis, your body's inflammatory reaction to that infection, which shuts your organs down and can lead to amputations in all too many cases and death in 350,000 cases each year in the US. So, we can prevent sepsis by preventing infections, and we can do that through, it's good hygiene by making sure we're all vaccinated. And then if an infection does occur, making sure that we are, recognizing through public education, provider education and training, if this infection is causing that inflammatory response, and to make sure that antibiotics are administered quickly. That is the way to keep an infection either from happening in the first place or from extending into something more complicated. When it comes to awareness, as a patient advocacy organization, we were very interested in finding out how much the public knew or didn't know about antimicrobial resistance. And we conducted a survey last year, in fact, with support from Pfizer in 5 countries, the US, Brazil, Spain, China, and India. And we found, perhaps not surprisingly, that just 52% of adults had even heard the word antimicrobial resistance before. So half haven't even heard of it. And about two in 5 say they wouldn't even know how to begin to describe it. No idea. And 17% incorrectly think that infections can lead to diabetes, and 13% think infections can lead to Down syndrome. So I think we have, an education opportunity demonstrated by the fact that we then, told the folks what antimicrobial resistance is. We gave them a flavor of it. And at that point, 80% indicated that they thought it was a major problem and that they were extremely concerned about it. So I think we have a huge opportunity with education, general public, healthcare providers, policymakers, innovators, et cetera, to raise awareness of what this is and that it is a near and clear and present danger.
I'd like to talk about, we're having this panel discussion at an incredibly newsy time because the CDC just last week released a very interesting report indicating that any sort of tenuous progress that the US public health community has made, and Dr. Boucher, I know you want to talk about what that progress, how to define that progress, but any tenuous progress that we've made in the fight over AMR has been kind of pretty much wiped out by the pandemic. So I'd like to talk a little bit about the results of that. And actually, I'm going to start with you, Dr. Boucher, because I know you're pretty clear on where the progress is and isn't, and how the pandemic contributed to the work that's being done on AMR, or our country's failure to deal with AMR.
Yeah, so great issue. And I think just for context, I think our failure to prepare for the pandemic we knew was coming. We didn't know it would be COVID, but we knew something would be coming, is part of the problem here, right? So since awareness arose at a governmental level, right, we've had a national action plan for combating antibiotic resistance. And it goes back to a 2013 CDC report that set the table of what kind of resistance we have. That was updated in 2019 and showed that we were making progress in the hospital, and that antibiotic resistant infections in the hospital were coming down a little bit. In the community, however, they were going up. So in people who've never encountered healthcare, we're seeing resistant infections, for example, in young, healthy women with urinary tract infections or skin infections like the one I mentioned in the football player. So that was kind of a good news story in 2019, just before COVID. Then COVID came, and all of us contributed to this problem, right? All of us in healthcare. We worried that COVID would be like influenza and our patients would get what we call secondary bacterial infections. That is, the virus would do damage to the lung, bacteria would come and set up shop. It could be rapidly fatal. So we used a lot of antibiotics early in COVID. We stopped focusing on infection prevention measures because we had to focus on the pandemic before us. Doubling, in my hospital, we doubled the size of our ICU almost overnight. If you think about what that meant on the ground in terms of the doctors and nurses and what we were doing. So less infection control, more antibiotics, bad recipe, right? Then we got better at caring for patients with COVID. We had drugs like remdesivir and others, and patients lived through the first part of their ICU stay and got into trouble with hospital-associated infections. And that called for the necessity of using more antibiotics. And the horrible outcome of saving a patient's life from the COVID, only to lose them from an antibiotic-resistant infection. So a lot of things together. And then lastly, stewardship, the best use of the antibiotics we have. The teams who were focused on stewardship before the pandemic all got redeployed to deal with the pandemic. So we weren't keeping our eye on that ball either. So I think the confluence of those factors led to what we saw in this report last week. And I'm honestly not surprised by it. But one thing just to emphasize for our audience is that, the message in the hospital kind of all makes sense in a way. But the problem in the community is getting worse as well. This is a problem that affects regular people like you and me who never have procedures in a hospital. And it can affect any and everyone. And I think that's a message I know that Tom and his group are working really hard to get out there, but it's here now and it can affect any of us. And I think that's something that I hope will resonate with our audience.
Well, Mr. Heyman, it sounds like she's kind of queued you up here, or teed you up to talk a little bit about what happens at home. I mean, what sort of awareness, what sort of education needs to happen outside of a hospital environment to maybe make progress happen that has not occurred yet?
Right. And I would say, I think there's a silver lining to this, horrific pandemic that has hit us upside the head, in that I think there's a much greater awareness now of the dangers of infections. Number one, COVID is a viral infection, and the distinction that needs to be made between a viral infection and a bacterial infection. And it has really shined a light on the fact that our clinicians are in that unfortunate position of making a diagnosis and prescribing a treatment with radically imperfect information. And I think that brings into play, the necessity of really thinking more and integrating more into our thinking and planning the role of diagnostics. And, so that we can not, have to kind of reactively give someone a broad spectrum antibiotic when it very likely could just be a viral infection, but we don't know. And we can't take the risk of letting it potentially become sepsis. So I think there's a silver lining here that we have all become much more aware through a hard path of dangers of infection and the need for better specificity about, one, what the insult is, what the infection is, and then also, our body's unique immune response to an insult, and really getting a better understanding of the heterogeneity of our response to infections. In terms of education, absolutely. We launched a campaign last year called End Superbugs, ENDSuperbugs.org. And we are really committed to making sure that the public knows that this is a clear and present danger and that they can play a role. And our survey showed that the public actually does think that they can play a role, not as critically as government's role, they believe, or pharma's role, but interestingly, that the public can play a role here. And perhaps, as my recent experience, having just had COVID, I was begging my doctor/brother for an antibiotic because my throat hurt so badly it had to be a bacterial infection. He convinced me otherwise, and it turned out to be COVID, viral infection, Paxlovid, and I'm not in the hospital. I'm here speaking with you today. So I think education can work, and it really is about engaging our communities and getting them activated about this danger. We do not want to go back to a pre-antibiotic era.
I've heard a lot about that sore throat, by the way, with this latest variant. So it sounds like it's no joke. Dr. Boucher, how, as a patient, can we advocate for ourselves to make sure that we're, being part of the solution and rather than contributing to the problem? I mean, Mr. Heyman talks about sort of how he had to deal with COVID and he wanted the antibiotic. So what advice do you have for patients to advocate for this?
Yeah, so there's a lot patients can do to advocate for themselves, right? So I think I'm a mom, I have 2 daughters, and I think that anytime an antibiotic is recommended for either yourself or your child or your parent, if you're taking care of an elderly parent, ask the question, like, what is this for? Make sure you understand what it's for. Make sure you understand how long you're supposed to take it, and that you're comfortable with that. Because every antibiotic also has side effects, right? So there's no free lunch here. And I think being open to the kind of advice that Tom got, that you don't need an antibiotic, is really important, because there are some patients who are more demanding, and it takes longer for a physician to go through that discussion of why an antibiotic might not be indicated. Or if it's your child, I had a child who had bad ear infections. Sometimes it was no antibiotic today, but we need to see her back in a day or 2 to re-examine that ear to see if she needs antibiotics. That's hard when you're a working mom and you're busy. That's hard advice to take, but important. Other things, think about animals, right? So this is what we call a One Health problem. Antibiotics are overused in humans, animals, and the environment. And there's an interplay between all of us. So it turns out our pets, dogs, cats, and others, are given a lot of antibiotics. And we have an antibiotic center here at Tufts working with our vet school and look into this, right? The antibiotics in meat story is kind of more well known, and we no longer use it as growth promotion in meat animals, but they're used a lot in so-called companion animals, our dogs and our cats. So there are a lot of ways we can participate. The other thing is, make sure when you're going to get a procedure, you're going to a hospital that has good infection control statistics. That's available publicly, and the best infection is the one that doesn't happen.
Where do you look that up?
Right on the hospital's website. It's on every healthcare system's website in America. Then the other thing I want to come back to is vaccines. Tom brought this up, and this is underappreciated. That vaccination actually prevents antibiotic resistance. And that sounds a little funny, but it's true. Flu vaccination prevents bacterial infections after influenza, which are a major killer, right? 36,000 people die in America from influenza every year, and a lot of those infections are preventable with, those deaths are preventable with vaccination. Our children are vaccinated for strep pneumonia that causes pneumonia, and meningitis in children. So getting vaccines, and especially with our children getting vaccines, very, very important. There's also a need for more vaccines to prevent resistant bacterial infections, and there are some groups investigating them. It's a very hard process to develop them, but they do work, and they're used very effectively. So I think it's important for consumers to understand that vaccines have those benefits in addition to the ones that they already know about.
Thank you. Can we talk a little bit about the pharmaceutical components of this problem? I mean, there has not been a new antibiotic in decades from what I've read and from what I think you said in an interview recently with Newsweek. I mean, how do we change that? And also, because I'm from CQ, I've got that interest in what does the federal government do? How does it address this problem? And what's role is it in helping to make this less of a concern?
Yeah, great question. So
for both of you.
Yeah, the antibiotic problem is very complicated, but fundamentally what has happened recently in the last 5 to 10 years is that the market for selling antibiotics has become broken, and large pharmaceutical companies have left the space. The development that's occurring is happening in small companies, several of whom have gone bankrupt despite developing antibiotics. And then most recently, we have not had a new antibiotic approved in our country since November of 2019. Very, very concerning for our patients. And so it's this failure of the economics as well as the other issues that have brought it to governmental attention, because it's a public health and a national security issue, as was pointed out beautifully by our senator earlier. So the government is interested because there is a public health and national security reason to be interested. And so the idea is to find a way to make there be truth to a return on investment for those who develop antibiotics for the most critical needs for the worst infections caused by resistant bacteria. And one such approach is the subscription model that is embodied in the PASTEUR Act that's now before Congress. And so the hope, many organizations, professional organizations, physicians like me and others, and Tom's group are supporting this initiative as a step. It's not the solution, but it's a tangible step towards addressing this problem.
Mr. Heyman, would you like to take a whack at it?
Yeah, I agree completely with Helen, not surprisingly. This is not going to get better on its own. Market forces are not going to fix it. We need to act collectively in concert with government to solve this. And I think we need to really step it up. This, let's replace the moonshot with an AMR shot. And, this is that big. And, you think back to, as you talked about earlier, how the impact of penicillin, when it first came in, and we're losing that. And this is a huge, problem and an opportunity that we need to work collectively together to solve.
Yeah, I might just add to that quickly, because I was asked some very hard questions by some medical students yesterday, and one of the questions was, if we just did better infection prevention and stewardship, maybe we wouldn't need these antibiotics. But that's actually not true, right? We have patients before us today with these infections that we can't treat. So they have a need today, and we know there'll be a need tomorrow, even with perfect infection control, because bacteria become resistant in nature. So we need both. We need good infection control and more antibiotics. And I think that's a message that I hope more people in the general public really can identify with, because that's at the crux of why we need to solve this problem.
Yeah, and I would add, the role of therapeutics, which, we got the vaccine, and then we realized now we need therapeutics, and therapeutics are here and are really helping. So it's all part of an equation, prevention, vaccine, diagnostics, therapeutics, stewardship.
You mentioned diagnostics, and I wanted to come back to that because I'm fascinated as well. I mean, if you get an AMR, how do you determine what AMR? How do you treat an AMR if you don't know what it is? So, can you talk about diagnostics? Are they where we need to be? We need them to be.
Yeah, I mean, as a clinician, I'll tell you, unfortunately, they are not. Right. So, a patient comes before me who is ill. I think they have an infection. I send off a test. The first thing I usually find out is that there's a bacteria, but I don't know if it's resistant or not for another day or two. So we have to treat them with antibiotics until we know. And that is challenging. And so Tom's disease, sepsis, minutes matter. Minutes to antibiotics matter. And you get one shot to get it right. So that does lead to some overtreatment, because we know that we could lose a life if we don't get it right. So having a diagnostic test to tell us whether it's bacterial or viral for things like, a flu-like illness, and then to tell us if the bacteria is resistant faster, are desperately needed. There's a lot of challenge to the reimbursement of those tests, right? We're talking about reimbursement of drugs, but the reimbursement of diagnostics is very complicated. And the regulatory path at FDA is different for diagnostic tests than for drugs. And that makes developing them in concert more complicated and takes longer. So I think those are just things to understand. It doesn't diminish the need to do this work, but it puts into perspective how long it's going to take us.
Do you view Medicare as part of a potential solution here at all? I mean, you were talking about reimbursements, so.
Absolutely, right? So a huge proportion of Americans that I take care of are on Medicare. And the way we at the hospital are compensated for caring for patients is what's called a DRG, a diagnostic relay group. So if a person comes in with pneumonia, hospital gets paid the same if I give them no antibiotics because it's a virus and they don't need antibiotics, or if I give them the most expensive antibiotic I have for a resistant infection. There is no difference. And so there have been movements and proposals to carve out the cost of antibiotics from that DRG so that the hospital or the health system could be reimbursed separately for using those drugs, of course, appropriately in, the rare instances where they're needed. But that's another model that deserves further attention, I think.
Do you all think there's sufficient data on AMR out there? I mean, would part of the awareness be helped by having better data on this issue?
Yes. Yes.
I guess it is a yes or no question, isn't it?
Well, I would say yes. And I think, we have an example with the creation of the National Cancer Registries within the CDC back in the early 90s. And, it's hard to imagine a day when we didn't have access to the cancer data that we have access to now. And, you see the mortality rates before and after the creation of that registry. And there's a dramatic change because there was much greater visibility into longitudinal histories and the heterogeneity of cancer. And Sepsis Alliance is calling for the creation of a National Sepsis Data Trust, similarly, so that we can track these infections and learn more about what kind of comorbidity did the person have, what kind of vaccines were on board, what kind of environmental circumstances are they living in, what kind of diagnostics were used, if any, therapies were used, outcomes, readmissions, to really help inform the work of the clinicians and policymakers, and perhaps most importantly, the innovators who are really struggling to figure out this, disease trajectory of infection to onto complications.
Yeah, and if you go to Europe, you can look at a map of Europe and hover down to the city and hospital level to see the kinds of antibiotic resistance they have. So the United States is not, once again, we're following our colleagues across the Atlantic, which I love them and love being their partner, but I think we could be doing better with our surveillance to understand the resistance that we have in our own locality and across our country.
I hate to jam this into the last few minutes of our conversation, but I do want to have a brief discussion about equity. To hear you describe it, I mean, this is an equal opportunity problem, but I do wonder about sort of a socioeconomic impact if you're not in an area that's got as strong a healthcare system. What impact does that have on your ability to get this or your susceptibility?
We have data that there are more infections caused by resistant bacteria and worse outcomes in those infections among people of lower socioeconomic classes with less access to healthcare and people of color. So a paper was in Nature Communications from our group last year showing this. A lot of work to be done, but very similar, sadly, to what we saw with COVID. So increased representation and worse outcomes and greater burden of morbidity and mortality in those groups.
Yeah, and we'll be publishing, we do an annual awareness survey, and dishearteningly, people of color are much less likely to have heard of sepsis or know the symptoms, and are twice as likely to have an incidence and twice as likely to die. Black women are 3 times more likely to die as a result of pregnancy, and we know sepsis is the #2 cause of maternal mortality. So we really have an upside down equation here where, we really have an opportunity and a need to do better at education, do better at access to treatment, do better at understanding bias in treatment. And, this is a major problem for all, but is disproportionately an even greater problem for underserved communities.
I'd like to thank you both for your insights. I'm going to give the floor next back to Josh Resnick. Josh, over to you. Thank you, guys.
Thank you, Jessica. I'd like to welcome Patrick Holmes, Science and Innovation Policy Team Lead of Global Policy and Public Affairs at Pfizer. Patrick, thank you for joining us.
Thank you, Josh. It's been a real pleasure.
Why is finding solutions to the battle against antimicrobial resistance such an important priority for Pfizer?
Well, so first of all, thanks to just a terrific set of discussions that we've already had, and just an outstanding panel. And I think they've basically said it all. This is a major public health threat, a major threat to patients, and a threat to global health security. And these are areas that are incredibly important to Pfizer. These are areas where where we're focused our R&D investments on, areas of serious medical need. And this is, as we've heard, a complex challenge from a policy perspective, and that's where my involvement has been focused on, is how to work with a group of stakeholders to collaborate and come up with kind of unique solutions to what's a really challenging problem. And maybe finally, this is also an area of historical interest for Pfizer. We have a long heritage in battling infectious diseases. You've seen most of it over the last few years, certainly, but also in the antibiotic and antifungal area, we've brought forward numerous pipeline agents over time. In fact, I'd be remiss to not mention that our penicillin was the majority of penicillin brought ashore on D-Day. But also, this is becoming an area that is very challenging from an R&D perspective going forward, and we've heard that today. The market just doesn't provide substantial awards for bringing new antibiotics to market. So given kind of the development risks, given the really challenging scientific solutions that we're focused on, it makes it, without that type of commercial opportunity in the future, it makes it really hard for companies like Pfizer to invest in the R&D needed and to take the risks to bring new antibiotics to market. And that's really what the solution that PASTEUR brings is focused on.
Okay, and you touched a little bit on the historical side. Looking forward, what should we consider to be the most important next steps regarding AMR?
Well, so this is an area that we've been focused on with multiple stakeholders really for the past 6 or 7 years. And given kind of how challenging the economics of the market are, how challenging the R&D investments are, multiple stakeholders, not only in the U.S. but globally, have agreed that there's a need for novel incentives to really help drive R&D investment going forward. And I think Senator Young used that wording, novel incentive, and that's what's needed. You can't really focus on paying per pill here. You really need to pay for populations or provide other types of incentives. And again, that's what the PASTEUR Act provides. So there's no time like the present. There's substantial interest. There's broad stakeholder support. We have global support from organizations like the G7 and the G20 to take action here. And we believe that the PASTEUR Act really offers just a huge opportunity for hopefully turning the corner here and coming up with real solutions that are needed from an antibiotic and antifungal perspective.
And Patrick, in your view, what were the most important points made today?
Oh, so I took a ton of notes here. First of all, thanks to Senator Bennet and Senator Young for their leadership on this issue. Senator Young did a great job talking about the human cost, the unifying theme that AMR could be, and what's obviously a very challenging political climate, as well as the novel incentive point that I mentioned. Senator Bennet focused on R&D and how we're truly blessed to have an incredibly strong R&D ecosystem in the U.S. and PASTEUR gives us the ability to take advantage of that and to hopefully help use that R&D ecosystem, use the private and public sector working together to come up with new solutions. I really appreciate that from Senator Bennet. Dr. Michelle McMurray-Heath did a great job outlining the latest data on AMR. Some of the impacts that happen to patients, the millions of patients that die every year based upon AMR, and some of the new data from the CDC. I'm sure I'm going to forget something here. Dr. Boucher and kind of the patient impact. She talked about having to be in front of a patient and tell a patient that they have no treatment left for an antibiotic-resistant infection. That must be devastating. And finally, Tom Heyman from the Sepsis Alliance. The patient piece here is so important. I suspect that everyone on the call today, everyone in the audience, knows of a colleague, a friend, a coach who's had an issue with a resistant infection. I'm certainly seeing it in my community more and more. And we can't forget about that patient piece. That's why we need to make these types of investments and what PASTEUR can bring to help really deal with those patient issues and hopefully, again, be able to kind of reignite and re-energize the R&D pipeline for antibiotics and antifungals going forward.
Thank you, Patrick. Well, that wraps up today's event. Thank you to all our speakers for joining us for this important and timely discussion, and to Pfizer for making today's dialogue possible. If you missed any portion of today's program, it will be available on rollcall.com and on Roll Call's YouTube and Facebook pages. Enjoy the rest of your day.